Hey, all right. So this time for this video, and possibly for the next one, because I might cut this into two videos again, we're going to be talking about cleft lip and cleft palate. And if you are following along with the slides, there is a lot more in the slides than we're going to be able to make it to today. So, or in any of the videos, I should say. So some of it I'm going to leave out. You're not responsible to know for the exam anything I leave out, but it is here if this is one of the subjects you're interested in. And there's a lot of citations on the slides if you want to dig deeper for your homework too. Okay, so first we're going to talk about different kinds of clefts. So this is something that you might need to know for the exam. You'll have some of these described to you, and you'll have to say which type it could be, or which of two types it could be. So this first one that you're seeing here, this is just, these all match up, by the way. A, B, C, D, E. These all match up right here, A, B, C, D, E. So if you're going through and studying on your own, I know it's kind of hard to see what these letters are, but it just goes A, B, C, D, E. So A, we've got unilateral cleft lip with alveolar involvement. So there's no cleft palate on this one. This is just going to be cleft lip. It's got alveolar involvement. We'll talk about that in a second, but you could, if you answered that this is cleft lip, that's totally fine. This is going to be a bilateral cleft lip, and I mean, unilateral, bilateral. Uni is 1, bi is 2. Makes sense. So moving on, then this one, we've got, again, a unilateral cleft lip, but now we're moving into having some palatal involvement here. So this is actually going to be like a cleft palate, like you would think about it, right? So you've got unilateral cleft lip with palatal involvement is C. D is going to be bilateral cleft lip with palatal involvement. And then E is an interesting one, is cleft palate only, which you can have. There's actually a sixth type that I don't have on here because it's difficult to show. It's called submucosal cleft palate. And that's actually going to be a problem. Like, everything will look normal. It'll look like this picture right here. What's missing is actually the musculature needed to move this portion of the mouth, I guess. I'll call it the mouth. It's this portion of the uvula. We call it the velopharyngeal port, or the velum. So they're lacking the actual musculature to move that. We'll talk about that in a second. Well, actually, it'll be more than a second. I think it's a little ways down. So first we're going to talk about just our typical cleft lip, cleft palate kind of thing in more detail, more anatomical detail. So what you're looking at here, this is essentially the roof of your mouth. This is, these teeth, this whole top portion of your mouth, this green spot on this map of a skull, basically. So there's two different bones that we want to focus on. There's more than two different bones in this picture. There's a couple different ones, but the ones that are in focus are two different ones that we need to know. So we've got here, you can kind of see, hopefully you can see this, that there is kind of a suture running along here. So this is called a, well, let me step back 1 second and talk about one that you can easily see. This long fissure right here is called a suture. That's where two bones are going to come together. You've got one that's running along right here as well. Now, down here, more towards your throat, this is going to be the horizontal plate of the palatine bone, and then on the front, more towards your, like the front of your mouth, your teeth and stuff like that, that's going to be the palatine process of the maxilla. So if you have taken 310 with me, or if you're going to take 310 with me, you'll hear this a lot. But remember that you have horizontal plate of palatine bones, so you have palatine bones. The palatine process is not on the palatine bones. So the palatine process is on the maxilla, but then there's also palatine bones, and they have a horizontal plate. So two things that are palatine, but they're not part of the same structure. You also have these alveolar processes here. It's basically just holes is what they are, and that's where your teeth go. So when we talk about alveolar, the alveolar ridge, we talk about alveolar involvement with cleft lip and cleft palate. That's this right here, this part of the bone that curves down and your teeth stick into it. That's the alveolar process. So when you say a T, your tongue is kind of pushing on this area right here. Or if you have a cleft lip with alveolar involvement, there's another suture right here, which you can't really see in this picture, but it doesn't close all the way. And so you'll have this open portion of that alveolar process. Okay, so when you have cleft palate, this long suture right here is the one that doesn't close all the way. In fact, depending on how bad the cleft palate is, you'll see that these shelves of the palatine process right here, they're sometimes called the palatal shelves or the palatine shelves, they stay open quite a ways. So you can have a large space in here or a smaller space. Different people have different sized gaps for their cleft palate, but this is essentially what's going on, is this suture doesn't close. When we talk about development of it, I think you'll see how that might happen. But remember this picture. Some people can kind of feel it. So if you put your tongue on the roof of your mouth, you can feel that the skin is a little different, right? Where those two processes, those two bones come together and create that suture. You can kind of feel it. I can feel a difference in skin running along the roof of my mouth down that structure. Okay, let's take a look at just a drawing. Whoops. We're going to go to that next. Okay. So here's a picture of just cleft palate. And this is what I'm talking about. You've got those, here's those palatine plates right here, and they're not coming together, right? So here's the palatine plate. It needs to be further over. This one needs to be further over this way. And if those were coming together, then you'd have a perfectly closed palate, right? You wouldn't have cleft palate. But unfortunately, you do have a cleft palate. And you can see that it's essentially that those are like too short. They're not as long as a normal palatal process. So that's kind of what's going on there. And this is what it looks like. This would be looking up into the nasal cavity, essentially. So we're going to talk about this in a second too, but just to orient yourself, now that you're seeing the picture, try, if you were going to say something like buh, like bears blow balloons or something, it's like totally stupid like that. If you can feel, like, drag out the buh, so go ahead and go buh. Do you feel that there's a lot of pressure inside your mouth when you're trying to say buh? If you had something like this, something like a hole in the roof of your mouth, you wouldn't be able to stop air from leaving. So it's hard to do, but if you can make your back in the back of your throat, if you can make your velum not close, and then try to say bears, it's hard. It's really hard to do because it like instinctively wants to close. Bears blow balloons, like that, sort of. It's really hard to keep it from coming. Go ahead and try it. You're going to sound like an idiot, but I already did. So you can do it too. But you can see how that creates kind of a intelligibility problem. It almost sounds like you're saying mares mow balloons instead of bears blow balloons. And that's because you can't hold in that sufficient pressure to create those high pressure consonants. So b, p, t is another one that requires a lot of pressure. But if you think about it, is actually one that's produced with no pressure. In fact, your velum is down when you say and ing, like that. So those are all nasals. The velopharyngeal port is open and air can come out of the nose. So if you have cleft palate, you're essentially always talking with nasals. Okay. So here is a picture of exactly what's going on. So here again we have the median palatine suture. This is the one that runs down the middle. This is the one that's not closing, improper closure when you have cleft palate. But you can also see on this picture that there's another suture running right here. This is called the incisive suture. And this is what is usually affected when you have cleft lip with alveolar involvement. So you can have this suture not close all the way. And this can, I mean, in this picture it runs out between the second and third teeth, but it could come between the first and second occasionally. The sutures aren't necessarily always in exactly the same place. And what goes on mechanistically with the cleft palate can kind of slide that suture a little bit one way or the other. So it's not always going to be in exactly this spot right where this suture shows that it's going to be. It's in this general region though, somewhere over here. And so it's going to come from up here in the alveolar ridge and move back towards the midline. And then, as you remember from that first slide, it'll either be just cleft lip with alveolar involvement, or this will also not close properly. So you'll have cleft lip with alveolar involvement and cleft palate. Of course, you can have both alone, but you can also have the two together. Okay, so let us move on. So now we're back to this slide. And this should make a little bit more sense to you now. Now that you know the anatomy and physiology of what's going on with the roof of the mouth, essentially, right? The anatomy of the roof of the mouth, now it makes a little more sense. You've got your incisive suture right here. This is what's open. You've got your palatal suture right here, and that can fail to close as well. So again, unilateral, bilateral, these are just cleft lip, and then unilateral, bilateral, these are cleft lip and cleft palate. This is just cleft palate. And if you had a case of someone with a submucosal cleft palate, it would look normal. And we'll talk about how to find that towards the end of the lecture. Okay, so this works better in person, but usually I have you just yell out what you think it is. But, you know, go ahead and test yourself. So the first one, what do you think it is? It's either unilateral cleft lip only, or it's unilateral cleft lip and cleft palate. We're not totally sure, because we can't see anything in the top. So we're assuming it's unilateral cleft lip, and the rest is undiagnosed. What about the middle one? If you said bilateral cleft lip of some sort, you're correct. And what about this third one over here? Why don't you, for your word of the week, tell me what that third one is? Your choices are A, B, C, D, E, or submucosal cleft palate. It's one of those. All right. So let's talk about how often cleft lip actually happens. It's 1 in 700 worldwide. So that's actually, I mean, it's not something that you would say is super common, but it's also not completely uncommon. 1 in 700 is not terribly uncommon. In fact, I wonder how many births there are in a day in the world. I don't know how much I trust this source. But it says 360,000 babies are born per day. 1 of every 700 of those is going to have cleft palate. That's kind of scary. That's a lot of people in the world. All right, so anyway, if you specialize in this, it would definitely seem that you are never going to be not needed. There's a lot of babies born every year, and 1 in 700 is going to need this kind of service. So these are a little bit different genetically, and we're going to talk about the genetic basis for cleft lip and cleft palate. It's not all genetics, which is interesting. So Asians and Native American populations have the highest incidence rates, a little bit above the worldwide average. It's 1 in 500 births per year. African Americans have the lowest incident rate. That's about 1 in 2,500 births. So that's a little bit safer there. Then we've also got a really interestingly weird disparity between males and females. So cleft palate only, just cleft palate, is more common in females. It's twice as common in females than it is in males. However, cleft lip of any sort is twice as common in males. And I mean, this kind of makes sense if you think about people that just normal people that with cleft lip. It does tend to be males. And then also if you think about any famous people, actors with cleft lip, it happens to be mostly males there too. I can't even think of a female actor with a lot of times, now anyway, the surgery has progressed so that you might not even know. It used to be that you were left with a scar. Depending on the severity of the cleft lip, you might still end up with a scar, but not always. Sometimes it's fixed really well if it's again a smaller cleft. You might not even notice it. So I guess it's really hard to judge just by looks. All right, and then again, cleft palate, you wouldn't necessarily, if it's cleft palate only, which is twice as common in females, you wouldn't necessarily even know. All right, so like I said, it's not just genetics that causes cleft lip. We know that there's no single cause. People have identified some genes that are linked with clefting. However, it seems like those genes can either be turned on or off by the environment. So if you think about it, you've heard stories of people saying like, oh, my grandma is 95 and she's smoked every day since she was 17 and she never had cancer. Well, cool. And then you have somebody who is like 40, they smoked for a couple of years and they end up with lung cancer, probably from smoking. And so we can say that, we know that smoking is related to lung cancer. We know that smoking causes lung cancer usually, but it seems like it also interacts with genes. There's some people who are just really resistant to getting lung cancer. And some people are very susceptible to lung cancer. And so the longer you smoke, the more of a risk you have, unless you have genes that are just extremely robust to lung cancer. So this is kind of that way as well. There's things in nature, things in the environment that can lead to cleft palate, and that will interact with the genes. So let's say it's someone who has the gene that could lead to cleft palate, and there's a disease during pregnancy or malnutrition, something like that. That could easily then become cleft lip. However, if you don't have the gene for it, you're very, protected against developing cleft lip. However, we do know that the second point here, that there are cases of isolated cleft lip or cleft palate, and that can happen when you don't have the related genes, and you don't have any related medical condition. So there's certain things like Chiari syndrome that are related with cleft palate. If you have, I think it's Chiari syndrome. Yeah, it's Chiari syndrome. You're very likely to have cleft lip, cleft palate with that syndrome. So if you have that, you're kind of out of that group that's just, got genetic predisposition to have cleft palate, because you have this other disease that cleft palate is a sub symptom of. So you can get it from this other disease. A lot of those are genetically linked as well. You can get just from having a genetic predisposition to having cleft palate, but then there are some people who will develop it without either of those. And then, like I said, there's also some other issues, chromosomal or genetic diseases that can cause cleft lip and cleft palate as well. So there's basically 3 different ways, and they can interact or they can't. They don't always have to. So it's a really interesting problem to have when we can't really pin down one exact cause. Okay, so here's where we're going to watch a video. So I've got all these pictures of what's going on during development, but none of these seem to show it as good as this video that I have. So this picture is pretty good. This shows, here's the palatal shelves. They're coming together, and they should link up right here and then fuse together. This is what should happen. So let's take a look at this video. Okay, so it's running through the entire development of the face. So I'm gonna speed it up a little bit until I can get it to where we actually need it to be. But this is the development of a face. I mean, oh, there we go. Now you can see how it actually looks like a face. And he's got a sweet chin strap beard. I'm not gonna lie, seeing this makes me a little bit more reticent to have children. They look so weird at these stages. It's a good thing we don't have to see them when they're in that. Here we go. Alright, so let's slow this back down. So you should have a palatal process coming out this way. So if you look right around here, this is where you should actually see. Let me get rid of these. Okay, so watch right around here, and we're gonna see the palatal processes kind of hinge up. I think it should be hinge up and then come together. Yep, here's the Palatine process right here. So they're going to move up and together. Okay, that was a little fast. Let's jump back. Slow it down. So these words are going to jump up on the screen. Maybe they already did. It's going to show that this is the Palatine process here and here. And we're looking at the maxilla bone right here. So you see, as it develops, they're going to come up and now start coming together. And it's at this point right here that can be occluded. Some research shows that something happens possibly with the tongue. The tongue gets pushed up and it doesn't allow the bones to come together. But that's in kind of the infancy stages of figuring out what's actually going on. So it may be that's true for some types of cleft palate. It might not be true for all types of cleft palate. But something is happening that is not allowing these bones to move up and come together like that. All right, so that is the formation of a non-cleft palate. You would expect that the formation of a cleft palate would be that they just wouldn't come together right there. And we're not seeing the lips here, but it should form at around the same time. We'd have, here's the upper lip over here, the hard palate. So we would assume that around this same time that these are coming together or not, that we would also have other portions over here coming together or not. Okay. So let's go back to our slideshow. All right, so one thing we need to talk about is the velum here. This is for submucosal cleft palate. So what we just watched, that's mostly for cleft palate when we're watching those palatine processes come together or not come together. That's going to be for cleft palate. This is going to be for submucosal cleft palate. Remember, if you remember, is when the musculature necessary for closing off the velum doesn't develop. It can happen with a process similar to the cleft palate. There's some malformation, and those muscles that govern this process just aren't there to pull up on the velum. So what is the velum? Well, it's this flap of skin and muscle right at the back of your palate. So if you take your tongue and run it along the roof of your mouth towards the back, you're going to feel bone, and then you're going to feel where it just gets squishy. It's just tissue. That's the soft palate. That's the velum. You can do it with your thumb or finger too. Try not to puke. But I mean, it's an online class. You're just at home. So you can puke if you want. So what's going to happen is the muscles are going to pull the velum up and press it against the back of the pharynx. Usually when you're pulling your velum up, the pharynx is also going to constrict. So what happens is you get pressure from multiple angles coming together to really close off the velum. What that's useful for, we talked about before, is saying buh, different things like buh, and other consonants as well. Buh, puh, tuh. Most of the time when we're talking, we actually have our velum up, or it's ready to go up. In fact, I'm going to show you a video of someone talking, and you'll see how many times per second the velum actually moves. It just kind of pops up and down really quickly, numerous times during speech. Velum is going to be down when we say, again, things like and Those are nasal, so we want air to escape the nasal passages. So if you have a submucosal cleft palate, you're not able to raise the velum to be able to close off the nasal passages. So all of the air is going to escape all the time. This is just showing essentially what I said before. We've got the velum is being raised by muscles, and then the pharynx is going to constrict from 3 different directions. The back of the pharynx is going to be pulled forward, and the sides are going to come together as well. So you get a really nice tight closure of the velum for a lot of your consonants, especially a lot of your high pressure consonants. This is exactly the same thing in 2 other slides. I wonder why I thought that we needed to go over it so many times. Okay, this is really interesting.
Back wall of the pharynx, thereby pharyngeal insufficiency, or VPI, is a medical condition characterized by hypernasal speech and, if severe enough, food and liquid nasal regurgitation during swallow. During normal speech and swallow, the soft palate closes tight against the back wall of the pharynx, thereby completely separating the nasal cavity from the mouth. In patients suffering from VPI, there is a persistent opening between the soft palate and back wall during speech, in this animation denoted by the green arrow. This opening allows air escape during speech and food and liquid nasal regurgitation during swallow if severe enough. Here is a MRI scan showing normal velopharyngeal movement during speech.
Okay, so I wanted you to hear what was going on there. They're talking about velopharyngeal insufficiency, which is something that we talk about with submucosal cleft palate as well. Submucosal cleft palate is a type of velopharyngeal insufficiency. However, it's not the only cause of velopharyngeal insufficiency. You can have velopharyngeal insufficiency that's caused by a whole bunch of things. So you can have submucosal cleft palate. You can have damage, nerve damage. You can have problems, temporary paralysis problems. There are other things that happen at birth that aren't necessarily submucosal cleft palate. Maybe the velum is just not long enough. And so that can also be a velopharyngeal insufficiency. So submucosal cleft palate is related to cleft palate, and the musculature that control the velum don't grow in. They're not present. There's nothing for them to attach to, possibly, because part of the osseous structure inside is deformed. It leads to velopharyngeal insufficiency. But leading to velopharyngeal insufficiency, there's a lot of roads that go there. So we can talk about velopharyngeal insufficiency, and we will, but know that it has multiple causes, not just submucosal cleft palate. Okay, so now I'm going to mute that dude, and we're going to take a look at this person's MRI scan while they talk. I want you to focus on the velum right here. Watch how many times it moves. And it moves so quickly, too. Down, 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 up. And then it, right there for a second, it was really, just kind of back and forth, back and forth. It's pretty fantastic. We're gonna leave this up, and we're gonna come back to it in a second, because I want you to hear. Well, actually, never mind. Let's just watch it now, since we're talking about it.
As shown with an MRI scan. Here are a few examples, starting with a normal endoscopic examination.
Pa, 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 pa.
Count to 10.
1, 2, 3, 4, 5, 6, 7, 8, 9,
Can you say shoe?
2.
Shiny shoes?
Shiny shoe.
Okay. Can you say seesaw?
Seesaw.
See the seesaw?
Sing a seesaw.
Good. Can you say sha 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 sha?
Sa, 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 sa,
Okay.
sa.
And say ka 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 ka.
Ka, 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 ka.
Good.
Let's do ma, ma, ma.
Mama.
Okay, before I move on, when she was counting to 10, 9 came out great. That's because n, again, it's a nasal, and it's okay if air leaks out through the nasal passages. So, cool. Sha is one that didn't work out very well. Sha. The reason for that is we're letting air leak out through our mouth. Shh. Like that for sha, but we do have the velum closed because we want to push the air out through the mouth. If we don't have good closure on the velum, we can't really say shh because there's a path with less resistance for the air to leak out through up through the nasal passages. But then she's able to say ka 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 really well because that happens back. It's a glottal stop, right? So ka ka. Well, it's not exactly glottal. It's slightly above that. It's a pharyngeal stop. But anyway, it is going to happen like right before where anything comes into play with the velum. So she can say ka 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 just fine. If the air leaks out through the nasal passages, if it comes out through the mouth, it's okay. She's still pronouncing it fine. So there are some sounds that are good and there's some sounds that aren't. And that is one of the ways that you can determine what's going on. Is there velopharyngeal insufficiency / submucosal cleft palate? Is there cleft palate? Is there cleft lip? So we'll talk about different speech problems with all of those different, which one's common to those different problems, again, towards the end of the lecture.
Ma,
And now say pa, pa, pa.
pa, pa, pa.
Ba, ba, ba.
Ma, ma, ma. 1, 2, 3, 4, 5, 6, 7, 8, 9.
Pa pa pa. Patika patika patika.
Good. Again. Again.
This is something that we can use to control for VPI to help get rid of VPI. These are called, speech bulbs is what they're called. They're calling it an obturator, but you'll probably know it as a speech bulb. Your clients will probably be more comfortable saying speech bulb than obturator. But essentially you put it in kind of like a retainer in the roof of your mouth, and it's going to push up on the velum and bring it it'll bring it a lot closer to being closed than it typically is. And so then you can use just a little bit of musculature to push that closed. In fact, it might be enough so that just the pharyngeal walls can close against this. You won't, if you have one, you're not able to get the velum open as much as you used to be able to, or as much as somebody that doesn't wear one of these. But you're able to speak essentially and say all the different phonemes that you're trying to say. We do have surgeries, which we'll talk about, that can correct for cleft palate and cleft lip. It's really hard to correct for submucosal cleft palate because we can't put in a muscle where there isn't a muscle. And it's really hard to correct for other types of velopharyngeal insufficiency because it is extremely difficult to rewire neurons if there's nerve damage. So anyway, let's go back to our slideshow. I feel like this might be where I end this one and start the next one. Yes. So we're going to end here, and then we're going to start the next one at the next slide.